Now we're going to go into some of the application of what you just learned, because really it's not only important for you to be able to recognize someone's postural deviation, but more importantly for you to be able to do something with it for your client. Okay, so this is really all about applying what you just learned into your training. So we want to use this type of training in conjunction with the other types of training that we include, which includes both cardiovascular and strength-based training. Again, we want to correct and strengthen. And so this is where, when we talk about corrective exercises, a lot of what we're about to go over are corrective exercises. So one of the biggest issues we see, as you remember from that last part of the lecture, is that kind of internal rotated upper body. So what you can see in this guy's posture is that you can see an overcontraction of the chest muscles. And so when the chest muscles are very, very tight, they constantly will kind of pull on oneself, right? So they kind of come forward like this. And then as a result, you start to see a rounded shoulder, you start to see your head come forward, and those back muscles have to be overly stretched in order to compensate for those overly contracted chest muscles. So again, just a review of what's happening in that shoulder joint. Okay, you remember your sits muscles. You have your subscapularis, your supraspinatus, your teres minor, and your infraspinatus. Okay, so all four of those go into that shoulder joint. And so when we think about trying to provide corrective exercises for that shoulder joint to help with kyphosis, right, we really have to think about the joint that's in question, which is that shoulder joint, and to think through how do the muscles that interact into that shoulder joint, how can we correct those muscles? So here's a nice kind of overview of thinking through that a little bit. So if you have someone, a client who has an internally rotated humerus, right, which is that kyphosis type posture, what may be going on? So again, we might have chronically tight and short pecs and subscapularis. What might be tight? Lats, maybe, okay, pecs, potentially, right, and so we need to stretch those. Subscapularis, okay, and coracobrachialis, say that 3 times fast, which helps with flexion and internal rotation, and then also that teres major, okay. We also might know that there's lacking strength in the infraspinatus or that rotator cuff. So we know what might be going on, we know what might be tight, what also might be weak. And so if we know that the chest is tight, we're thinking that potentially there might be weakness in there as well. So that infraspinatus, which helps with that external rotation, teres minor, which also helps with external rotation. So if we know that they're here a lot, we want them to be able to do this, right? We want them to be able to take those shoulders, bring them up, back, and down. In order to do that, we need to strengthen, if you remember going back to your anatomy, that teres major and minor, which are right kind of in by that infraspinatus, okay, which is in that posterior side of the shoulder joint. So that's why we really think that we need to strengthen the infraspinatus, teres minor, posterior delt, potentially even the rhomboids and the mid-traps that are in that back area. So now just a reminder, it's always good for us to kind of remember what muscles go into those different joints. Get Body Smart is a nice website because it kind of can show you based on the movement pattern what muscles are being included. So just another little tidbit of information for you to use. So what I want you to think through right now is from a practical standpoint, we want to make sure that if we have someone who has that rotated shoulder, right, in kyphosis posture, what are some stretches that we can do to help them correct their posture, right? Because stretches are very much a corrective exercise. So the first picture here, if you're looking at this photo, the person has their arm up on a wall and they're kind of leaning down. You can do a similar stretch on the TRX or any suspension trainer. That is going to primarily be stretching the latissimus dorsi. The second photo where you kind of that wall stretch you've seen or door jam stretch is going to primarily stretch the pecs. The third photo is primarily going to stretch that subscapularis. The fourth stretch is going to primarily stretch that coracobrachialis. And then that fifth stretch, kind of that tricep stretch, but with the kind of lateral rotation, is going to stretch that teres major, okay? Really important that we know these type of stretches and that we're incorporating these for individuals who have that kyphotic posture. Here's some other stretches that might help, okay, and these are things that might actually strengthen some of those muscles, okay? So this first motion of doing this, okay, it's a lateral and external rotation of the shoulder, and that's going to help with that infraspinatus. Number 2, okay, you've seen this, a lot of PTs will do this movement, okay, or laterally, That's really going to help strengthen that posterior delt and teres minor. And then that third strengthen exercise, we've all seen this one before, right? A seated row. It looks like a hybrid between a narrow and a wide row, and that's going to help those rhomboids and mid-trap. Let's move on to that second posture deviation that we see a lot. So we first talked about kyphosis, now we're going into the valgus knee position. And so when you look at these photos, hopefully you're thinking that kind of makes you cringe a little bit, right? So you see when someone's coming into this kind of squat position, or if they're running, or if they're landing from a squat position, you see that those knees are internally rotated from alignment of the hip and the ankle joint. And if you have this internal rotation in the knee, that's going to cause some chronic issues, right? So that means if they're chronically doing this movement pattern, all the joint loads are going to go medially rather than centrally located within that joint. So if you look at both of these photos, I want you to be able to understand which one is valgus and which one is varus. And one is actually not varus, one's a little bit more kind of a neutral alignment. So looking at both of these, which one is valgus? And again, valgus being medial rotation of the knee. And if you're saying B is valgus, you are correct. C, what you can see is that knee or patella is in line with the toe. So that actually is pretty good joint mechanics. If you were to have that knee then go outside, so a little bit more laterally, that would be what we call varus. Okay, so valgus is having the knee coming medially, varus is having the knee going laterally. So here's another, again, similar to what we just did with the shoulder joint. What might be happening in that knee during a valgus knee posture? So indicators during static or dynamic movement, it's really not as obvious without movement. So having someone go through a moving pattern to see if that valgus exists is really helpful. It is common, valgus knee is more common with people who have a wider Q angle, which is most women. And again, you have that knee inward collapse, and sometimes it's coupled with foot pronation. Okay, so going this way rather than going this way with your foot. So what may be going on during valgus knee? It could be that someone has tight ankles or they're having issues with dorsiflexion, mobility. It could be that they have tight lower legs in general, so all the musculature around that area. Again, it could be that there's this pronation that's happening that's allowing that knee to migrate. So there's a number of things that could happen. So pronation meaning pronation at the foot that's causing that knee to come into that valgus position. Here are things that you shouldn't be doing. If someone has a valgus knee position, if you simply tell them to straighten their knee, they're not going to understand what you mean by that. Because for them, they have altered their body mechanics so that they are moving in a way that's most efficient for them. So if you tell them to strengthen their knee, they're not going to quite understand. And so what you really need to do is to address the subtleties and the things that are happening above and below that knee joint, right, including the ankle joint, to help correct that posture. So things that might be tight for someone who has a valgus knee, that calf muscle, that gastroc and soleus, anterior tibialis, right, the shin, and then potentially having hip adductors that are a little bit more overactive than they should be. Things that might be weak, glute min, glute med, right? So if we have a strong glute min and glute med, that's going to pull out our knee in better alignment with our hip and our ankle. Same thing with glute max, and then a stronger hip external rotator. And the reason why this little yellow piece at the bottom, this is the kind of a justification for why we shouldn't just tell them to strengthen their knee joint, is because after someone learns a neuromotor program, it's really difficult for them to reset that. And so that's where it's less about telling them to strengthen their knee or simply straighten their knee, and it's more about addressing the issues that's causing that to happen. Here are some stretches that can help with that. You have your kind of simple gastroc stretch, soleus stretch in picture 2. Picture 3 is that anterior tibialis stretch. You can also use myofascial release for this as well. Number 4, both of those photos will help with those hip adductors. Now looking at different strengthening exercises to help with someone who has valgus knee, working on that glute min and med, that's picture 1. Picture 2 is working at that glute mid and medialis. So again, making sure that we understand the differences between our glute min and glute med is really important. Number 3 is going to help with glute max. Any kind of major hip extension is going to help. So whether you do glute bridges, if you're doing squats, lunges, those kind of movements are going to help with the glute max. And then number 4 is a hip external rotator. And this is one of those that I would love for you to try. I've hyperlinked it here. because it's one of those things that oftentimes we think we're really strong, and then when we try to actually work on some of these very small muscles, they actually are a lot more challenging than we think. So now let's go into that third most common postural deviation, is that forward head tilt. Nice little photo here, but you see a forward head tilt. This is actually not uncommon in individuals, even young individuals. So let's look at what might potentially be happening. Some indicators are you have this jutting forward of the head and chin, and that tends to happen more so with the overhead squat. So if you're having your client go through these basic movement patterns during an overhead squat, look for that kind of forward head, not just tilt, but kind of just jutting forward. Some things that might be happening is that there could be an injury or weakness that's like straining that muscle. So they might be going forward because that's a kind of, again, a reactive thing. It could be that they need to shift their center of gravity forward. So those are some things that might be happening. What you can do is apply corrections from the floor in the spine position first. So when you have a forward head tilt, the first thing you want to do is start at the floor to see what's happening in the spine. So what that means is have them lay down, and if they're laying down on the ground in a supinated position and you still see that they're forward tilting or they're moving their head forward, that could be an issue, right? They might have a weakness or an injury that's causing them to continue to do that thing. If they're laying down and they don't do that, that means they're likely, when they do it when they're standing, they're likely doing it to shift their center of gravity, okay? So things that might be tight with someone who has a forward head posture. They could have tight pecs, they could have the upper trap or levator scapula that's really tight. Any of those neck muscles, including the sternocleidomastoid, which is my favorite muscle, by the way, those might be tight. Latissimus dorsi. So essentially thinking through that kind of upper posture muscles, so the neck and in that upper back. Any of those muscles potentially could be tight. What might be weak? Okay, we might see our serratus anterior, potentially our rhomboids. So our rhomboids are those muscles that kind of run along the spine, right? If those are really weak, that explains why the head would be forward in that forward posture. If our posterior rotator cuff is weak, same thing, that's going to allow the head to go forward. So now let's look at some different things that you can do to stretch and strengthen the neck. The neck is something that you have to be really careful with, and so these are all kind of very standard exercises that you can apply. If someone is having continued issues with that forward head movement and their neck is something that is hurting them, this is where you go and you reach out to people who are a little bit more qualified in that area. So having a physical therapist that you can reference is really important. So some basic neck stretches, you can see kind of one of the first things for strengthening is kind of actually moving that chin backwards so they can see what that feels like when their center of gravity is actually equal. Actually having them go and do this kind of movement or just laterally, knowing that you're doing each of these kind of safe and slow and controlled. Having them move their head forward, left and back. This posture here that you see, this has actually been done in multiple studies where you put your hand here, or the physical therapist will do this, and then you have the individual kind of push their weight against that hand, and that way they can kind of build that musculature in that upper back, and then again opening up the chest and again trying to strengthen that upper trap, sternocleidomastoid, all those muscles in that area. So now we want to move on to FMS, and FMS is a very applied skill, and it's something that you all will kind of need to learn in lab. I know some of you have experience in FMS from other classes, or maybe some assessments that you've done, maybe some conferences that you've gone to, but for those of you who are not as familiar with FMS, I really want you to familiarize yourself with the process before you come to lab. So there's a few ancillary materials that are on Beachboard. So in addition to watching these lectures, I want you to look at some of those materials. I also want you to watch this video. So this is a nice short video on what FMS is and how you can use it. And what I want you to do is I want you to write down what's the purpose of FMS testing. Okay, what are the purpose of all the testing that you see? How do you determine the scoring? How would you score this test? And what do you do if your client has pain within a movement? Okay, because FMS tells you what to do with that. So this will be something that I will collect at the beginning of class. So make sure you write these all down. Even if you know FMS really well, make sure you write this all down on a piece of paper and I will collect it in lab. If you have any questions, please let me know.